just to kind of give you an overview, really, of the sore throat test and treat service that we've developed over the last year within NHS Wales, and really what our plans are going forward. So I guess if we start by going back a step and talk a little bit about how community pharmacy in Wales is changing at the moment. As you probably all know, community pharmacy has always been remunerated on a supply function. So pharmacists have been paid for supplying medicines to patients. And our current Chief Pharmaceutical Officer and NHS Wales are very much looking to change that model going forward, and we're currently halfway through a 5-year transition programme which is looking at repurposing some of that funding that currently sits within remuneration of medicines and moving it more towards supplier services. And I guess the vision for community pharmacy is that we will retain that traditional community-based values of community pharmacy, but we will deliver services that are fit for the 21st century primary care in Wales. Part of the work that we're doing is looking at these 5 C's that Andrew Evans always refers to. So if we're going to move money and we're going to ask community pharmacists to deliver different sorts of services, we need to ensure that there's capacity within the network. And linked very closely with that is ensuring we've got capability within the network. And I'm sure you've all seen there's been a number of announcements recently where the Minister has announced additional funding to train community pharmacists in things like minor ailments and independent prescribing, and also support technician roles by increasing the number of medicines management technicians in community pharmacy. We also need to ensure that our network is working collaboratively within primary care, so there's lots of work at the moment. For those of you in general practice, you will see community pharmacists wanting to come and visit you more often to discuss local issues where you can work more closely together. And one of the, I guess, the big criticisms of community pharmacy services in the past has been around continuity. So making sure that we've got pharmacists in pharmacies that can deliver services every day of the week when patients need them. The other thing that we've been working on quite a lot, which is kind of, I guess, one of the things that I do for part of my week anyway, is working on connectivity and ensuring that community pharmacy is integrated within the NHS Wales network. I'm sure you've all seen the parliamentary review and the subsequent Healthier Wales, and that talked a lot about Wales needing a different model of care. And what we've been trying to do, particularly within NWIS, my role there, is to look at how we can integrate community pharmacy technologically to enable transfer of information to improve patient care. And that's really what we've been working on over the last 5 years within NWIS and the Choose Pharmacy application. So there are already really good links between GPs and hospitals. Community pharmacies kind of sat outside that network, so they weren't linked to any clinical systems. Their own records stayed within their own pharmacies, and they couldn't be shared outside of that. So part of the work we've done is develop this community pharmacy gateway, which enables us to start sharing information between different healthcare settings. We've kind of established that through Choose Pharmacy in various models. The bit on the right, working with NHS 111, is our next piece of work. So we're integrated with GPs and hospital systems to a degree, and we're working on that link with NHS 111 when they procure their new clinical system, hopefully by the end of this financial year. Just a little bit about what Choose Pharmacy is. I'm sure lots of you have heard me talk about Choose Pharmacy over the last couple of years. We started developing it in 2013, and it was part of Welsh Government's commitment to integrate pharmacy. There was funding given to by Welsh Government innovation funds to NWIS to develop the application. And what we've worked on over the last 6 years, I guess, is getting to a point where we've got a platform which is secure, so it is restricted access to pharmacists, and we monitor that and we ensure that only pharmacists who are accredited to provide services can access the clinical system. It enables pharmacists to develop an electronic patient record, and that record then forms part of a patient history. So if a patient represents at the same pharmacy, the pharmacist will be able to see what's happened in the past, or if a different pharmacist has seen them, there'll be a record of that consultation. The record can also transfer between any pharmacy in Wales. So if a patient moves their registration to another pharmacy, then the record will go. So again, it improves that information available to pharmacists when they're making decisions about patient care. We've also enabled access to the Welsh GP record for pharmacies making emergency medicine supplies, and they can access electronic discharge letters from hospitals with the MTED application when they're providing the discharge medicine service. So we're really starting to work on providing information to improve that kind of decision-making for pharmacists. And that, I guess, ultimately means that we've got improved patient safety because you've got more information, you've got relevant information, and you can use that to inform your decision-making. So if we go to the Common Ailment Service, which I think now is available pretty much everywhere, so we've got 716 pharmacies in Wales. The application is now available in 704 of those, and all health boards in Wales commission the Common Ailment Service. In Cwmtaf and Betsy, we've run it since 2013, and we ran it as a pilot initially, but what we kind of saw as we've started looking at the historical data was that for sore throats, we weren't really seeing the number of consultations we were expecting. We expected it to be up there in the kind of top 3, and we certainly weren't seeing seasonal variation in presentation either, which kind of was unusual when you looked at other conditions like conjunctivitis, where there was a lot of activity, and hay fever, where there was a lot of activity, particularly in the spring, summer months. So within Cwmtaf, we did a piece of work with our GP colleagues and our community pharmacists to understand really what maybe were some of the barriers around patients presenting at community pharmacy with sore throat. And what we kind of got from that really was there were a couple of things. There was something around patients and the expectation that they needed antibiotics. So when they presented at the pharmacy and they realised that antibiotics weren't available, they were moving to GP to kind of reinforce what they believed was the treatment they needed. Pharmacists were quite comfortable in talking to patients about their symptoms, but because the Common Ailment Service is based really on a conversation with the patient about symptoms and not really a more in-depth clinical assessment, where there was some question as to whether or not maybe that person had a strep infection, pharmacists were erring on the side of caution and they were referring those patients on to their GP colleagues. And there was something as well around safety netting and making sure that patients were getting absolutely what they needed at that time. When we talked to our GP colleagues about the referrals coming back, a lot of them felt that actually the pharmacists were well placed to manage those if the assessment was more robust. So what we looked at were there any services available where we could develop a model to increase the offer of community pharmacy to manage sore throats better in the community pharmacy setting. What we came up with was obviously the sore throat test and treat service, and this is what we aim to do within that. So we wanted to transfer the care of uncomplicated sore throat from GP practice to community pharmacy, to encourage collaborative working so that there was a really good relationship between GP practices and community pharmacy so that patients could be moved between those services as appropriate. We wanted to make sure that we were working to the antimicrobial agenda, which is obviously huge, and to ensure that community pharmacists, if we were giving them the ability to prescribe antibiotics, that they were doing that in accordance with national guidance and the principles of stewardship. And we also wanted to do some work with patients to reinforce that message that patients don't always need to see the GP and that there are the health professionals out there that can manage symptoms appropriately. So the next thing we looked at was, were there any models out there that had been evaluated to see if there's anything that we could build on. And we found a feasibility study that Boots did back in 2016 up in the Midlands. It was quite a small study, and it was picked up by a number of clinical journals. And whilst I guess the principles there were recognised as being of value, there was some criticism of that very small pilot in that they didn't follow patients up. So we didn't know if those patients who presented at the pharmacy then went on to receive treatment elsewhere. So we took that model and we took the feedback from that evaluation and we used that to kind of develop the Cwmtaf and Betsy Pathfinder services. Very fortunately for us, around the same time, NICE published 2 pieces of guidance around management of sore throats. There was the clinical guidance in January 2018 about management of acute sore throat, and then hot on its heels in May, there was a piece around the use of point-of-care tests in primary care for managing strep A infection, which fitted very nicely into what we were trying to deliver. So in a nutshell, the service involves clinical assessment. So that's using fever, pain or Cento to assess clinical symptoms. There's a point-of-care test, but the point-of-care test is only used where patients score highly on those clinical scoring systems, so not everybody gets a point-of-care test. There's symptomatic treatment, which is evidence-based as part of the Common Ailments Formulary, which AWTTC developed for us. There's an option of antibiotics where you've got a positive strep A test. And there's also a safety net in, so advice to patients about what to do if symptoms don't improve or if they worsen in a short period of time. And for those of you familiar with the guidance, we adapted it from NICE to fit in with those kind of principles. In addition to developing the model, we also needed to do some work around Choose Pharmacy to, build in this new service into the Choose Pharmacy functionality for Common Ailment Service. And the reasons for doing that really is we wanted to make sure that there was absolute consistency around that clinical record, so that pharmacists were recording all those kind of key important clinical elements to inform that decision making. We've built in links to clinical guidance, so we've built in links to NICE, to antimicrobial formularies, and we've built in links to the patient group directions that the pharmacists use as well, so they've got those on hand when they're providing the consultations. The fever, pain and scent or scoring tools are integrated into the application, so they are part of the core work that they have to complete. We also built in a requirement for pharmacists to contact patients 10 to 14 days after the original appointment to follow those patients up to find out what had happened to them. Obviously, that is based on patient discussion. We are looking at whether we can do some more work with getting information out of GP systems, but at the moment it was based on what patients told us. And the application also generates a consultation summary, which includes the key information from those consultations to go back to the GP. Training was kind of a key element. Whilst community pharmacists are used to managing minor ailments and they see patients with sore throats quite often, this was kind of taking it to a different level. So the training was really focused around the clinical skills and around taking patient histories. There was a lot of work around recognising red flags and complications of strep A. There was a lot of work around safety net and advice to make sure that pharmacists were absolutely clear of when they should be treating and when they should be referring and where they should be referring to. There was a session on antimicrobial stewardship. Scottish flag is for you, Avril, because she did a big session on the reason we've got antimicrobial stewardship is because of the Scots. So that was really important for the pharmacist to understand that big agenda around antimicrobial stewardship. And we also did sessions on what the service looked like, what Choose Pharmacy looked like, and using PGDs for antibiotics. So the Pathfinder was commissioned in November 2018 in Cwmtaf, and BCU came on slightly later in January. We looked at the pilot in pharmacies that were actively engaged with the Common Ailment Service and already had really good relationships with their GPs. And the service was evaluated. It was led by NWIS, by Dr. Effie Matsarani, with input from Cheryl, myself, and lots of other people as well. The evaluation is due to be published, so I can show you some information, but Effie has told me she's going to kill me if I present too much. So this is high-level data from the evaluation, pending Effie's official report. So if we look at what those aims were, so around transferring care of uncomplicated sore throats. During the 6 months now of our pilot, we've seen 1,725 patients with a sore throat. And one of the things we asked patients is what would they have done if the service hadn't been available on that day. 94% of those patients would have gone to see the GP. If you compare that with common ailments, it's about 83% would normally see the GP. So we are seeing more patients through this service, and more patients would have sought other care rather than self-caring if it wasn't there. The bottom graph, which I hope you can see, is just Cwmtaf data, and it just kind of goes back really to that thing around we weren't seeing consultations and we weren't seeing seasonal trends. The number of people coming through the service has increased significantly since the introduction of this service, and we're starting to see a reduction. We've done some work with one practice around a reduction in the number of patients presenting at the GP practice for a sore throat. So in terms of targeting that transfer of care, it certainly looks like we're moving in the right direction. We also wanted to look at, obviously, encouraging collaborative working. All the pharmacists had to visit their GP practices to talk about the service and to look at referral pathways both in and out, so patients coming into us, and also if patients needed to be fast-tracked to a GP, that process was in place. Again, from the results, 60% of patients who come into the service are referred by their GP practice. And again, if you look at the standard common ailment service, it's only 34%. So it kind of shows us that GPs have confidence in referring into this service more so than maybe they did in the past, particularly around the pieces of work that people did. And of all the patients that have been referred into pharmacy, 90% of those are managed by the community pharmacy. So 10% are referred back, usually because there are other symptoms which indicate more serious illness. Around antimicrobial stewardship, the results that we're seeing so far are consistent with NICE in that where you use point-of-care testing and clinical scoring, you get more diagnostic confidence. And from our study, 80% of patients coming through the service do not receive antibiotics. So our antibiotic prescribing rate is 20%. There are studies within primary care to look at antimicrobial prescribing rate for acute sore throat, and they run at about 60%. So we are kind of quite comfortable that our service is well within the kind of range that we were expecting. We also, by using point-of-care test and clinical scoring, so clinical scoring first means that patients who are asymptomatic strep A carriers do not get antibiotics, so they're screened out before point-of-care tests because they will score lowly on Cento. We also follow patients up to see what happened after, because we were concerned that obviously you can treat a patient in a pharmacy, but you don't know if that patient is then going to take that advice or they're going to go somewhere else and look for a different outcome. We asked all patients if they would be followed up. 300 patients did give us feedback, and we did manage to follow those up. We did a particular piece of work with this sample of 84 patients that were representative of the patients who came through the service. So they were patients who did receive antibiotics, didn't receive antibiotics, and there was a good age range there. Of the 84 we followed up, only 4 needed antibiotics on the subsequent appointment with the GP, which kind of shows that the majority of patients are managed safely within community pharmacy. But we recognise that point-of-care test isn't 100% effective, so that kind of 4 fits in with the kind of specificity of the test. The last little bit around patient education. It's always difficult when you ask patients were they happy, but it was patients do tell you the truth. We did have 98% were very happy, 2% weren't so happy. But I guess 98% success rate is as good as we can kind of hope for. And they would return to the pharmacy for a sore throat assessment again if they needed to. We've also kind of looked at supporting the AMR messages with patients. What was really interesting was the satisfaction with the service was independent of whether or not antibiotics were given. So we didn't see patients who had antibiotics being really happy with the service and the patients who didn't get them not being happy. There was no kind of correlation between the supply of medicines and satisfaction. And also the feedback that we had from patients kind of started showing that patients understood why point-of-care tests were being undertaken, and also the differences between bacterial and viral infections, and that they didn't need antibiotics for a viral infection. So from that perspective, that was really positive, and that some of those messages for patients were starting to get across. In terms of where we're going next, at the moment, consultation summaries from the service that are generated by Choose Pharmacy are on a piece of paper, which gets sent to the GP practice. We are due to start trialling electronic transmission of that information to practices in BCU later this month, next month, depending on when I finish my testing. So it's ready to go, and that should hopefully, again, increase the speed at which relevant information gets back to practices and kind of tie that off in terms of we're not passing pieces of paper between services. NHS Wales health boards are all looking to pick this service up and use it as part of their winter pressures planning. So all 7 health boards are keen to use this service. Probably we won't have it everywhere this year because scaling it up is quite a big piece of work, but certainly there will be the service available across Wales this year and more so next year. And we're also continuing to work with GPC Wales around access to the Welsh GP record for all services within Choose Pharmacy, but particularly for this sort of service where that information would be really helpful. Next steps is just around taking this forward, really, so scaling it up. So we need to do some work with the contractor representative body around agreeing a national specification. We need to kind of build on that training and work with HAW to make that part of the integrated model of community pharmacy training. We need to look at reviewing antimicrobial treatment in line with national guidance, so working with AWTTC, publication of our evaluation. And the last little bit is around the professional record standards body have just produced a huge piece of work around what information needs to be included in community pharmacy records and what information needs to be transferred to GP practices. So we'll be ensuring that we incorporate that into the design of the service going forward. So very last slide for me, just in summary, from our Pathfinder service, the service has been well received by patients and pharmacists and by the GP practices working in the areas where we've piloted it. We've got really good patient satisfaction, and we are comfortable that we've got a safe and effective model. And that's just a summary of kind of the evaluation that I've put up there. And that's it. Any questions?
Thank you, Emma.